Good day, good afternoon, everyone. Good afternoon, everyone, and welcome to our first panel of the International Pain Management Day, organized by Metrum Cryoflex. My name is Beata, and I'll be the moderator of this session. Our topic today is about one of the most promising and evolving areas in interventional pain medicine, cryoanalgesia, and how it can help to reduce chronic pain. Chronic pain affects millions of people worldwide and often resists conventional pharmacological treatments. Interventional approaches, such as cryoanalgesia, are offering new hope for a pain-free life. Today, we'll not only discuss the science and mechanism behind cryoanalgesia, but also explore clinical insights of performing it effectively, from diagnostic accuracy to precision in targeting peripheral nerves. I'm delighted to welcome two exceptional experts, beautiful ladies who combine science, experience, and practical wisdom. Dr. Dr. Andrea Trescott, anesthesiologist
We're
and
interchangeable.
a world-renowned expert in interventional pain medicine, joining us from Jacksonville, United States, and
From
Agnes Togic.
from Tonga, South Pacific, to be
Sorry.
honest,
Okay. And Agnes Togic,
right now.
board-certified anesthesiologist and pain specialist at Pain School International Pain Clinic, recognized for her work in image-guided interventions and education, connecting from Budapest, Hungary. Is that right?
Nice to meet everybody, see and meet everybody.
So welcome, Dr. Trescott and Dr. Stogica. Thank you for being here. Let's start. Let's start with the basics. Dr. Trescott, could you explain in simple words, simple terms, what cryoanalgesia is and how it works to reduce chronic pain?
Well, the word itself, cryo being cold, analgesia being pain relief, really describes exactly what it is. It involves taking cold and putting it directly on a nerve to kill the nerve. But killing the nerve and at the same time leaving the architecture there so the nerve can grow back along its normal pathway. I think that's the thing that's so particularly unique about cryo is that it gives you a period of significant pain relief followed by the opportunity for the nerve to grow back normally. And so you have this unique ability to provide pain relief, get the patients the rehabilitation they need, and then the nerve grows back the way it should. And so that's what makes it, I think, so very fascinating and something that Dr. Stogica and I have just become so enamored with. I started doing this about 30 years ago with cryo, and it has been one of my favorite techniques.
Okay, thank you for great explanation. Dr. Stogica, from your clinical experience, how do patients typically respond to cryoanalgesia? Which chronic pain cases benefit the most? So, in other words, tell us more about the indications.
So let's to think about cryo. Let's group the patient in two bunches. Okay, one bunch is a patient who does not have a nerve problem, but have a problem that we cannot fix, like a musculoskeletal problem, and we will denervate the joint. And the other bunch who actually do have a nerve problem, like a nerve injury, a neuralgia, a neuroma, and then in both cases, hitting the nerves eventually. Here, we treat them because it's a problem, it's damaged, it's hurting. And here we treat the nerve because the joint itself is a problem, and we don't know better to denervate. So thinking of Staying with nerves, essentially any peripheral nerves that we can identify, understand, and target is amenable to cryoablation. The key here is to have a good diagnosis, a clear picture both in our head and clinically, and which nerve is it problem. Okay, and we can confirm our diagnosis with a diagnostic injection we'll talk about maybe later because it's an important aspect. And then we can think about musculoskeletal, which is now the hot topics are knee denervation, hip denervation, shoulder denervation, for all those patients that are not quite right for surgery for many reasons, or they don't want it, but we can't help them with regenerative medicine so much. I think that would be a short little summary of my view indications.
Okay. Okay. Do you, Dr. Trescott, would you like to add maybe your like the first choice procedure for you? Like your
Well, I
best,
think
like your
it is.
favorite indication.
I think my favorite indication was probably the very first one that I found that I started doing cryo for, which was the superior nerve. I had identified as an anesthesia resident that this nerve caused pain. And for most people, a little bit of local anesthetic and steroid would give long term relief. But I would have those patients in whom the local anesthetic would make them numb, would take away all the pain, but then the pain came right back when the local anesthetic wore off. And so I looked for something to do for those patients and stumbled on the idea of cryo. And it has been, without a doubt, the most satisfying uh, technique. And it does fascinate me. People say, "Oh well, you don't want the nerve to grow back, do you?" And I said, "No, no, no, you do. This nerve was supposed to be there. You just don't want it to
Mhm.
grow back with pain." So I had the pleasure just a couple of weeks ago of seeing a patient that I had treated 20 years ago for an abdominal nerve entrapment of the abdomen. Had made the diagnostic injection, had done the cryo. She had had more than 15 years of relief, and then the pain came back, and several years trying to find where I was because I had moved to Alaska and had just moved back. She showed back up in my clinic. I refroze that same spot after the diagnostic injection, and her follow-up appointment 2 weeks ago, she was pain-free. And so the ability to give people long pain relief, not because the nerve stayed dead for all that period of time, but because the nerve was able to grow back in normal environment. So one of our mentors, Dr. Gabor Rex, used to say that the after cryo, it can last for a few days up to a lifetime. And
Okay.
that is true as well. If you've only gotten close to the nerve, if you haven't actually completely frozen the nerve, then you'll have short-term relief. But if you are accurate in your placement of the probe and accurate in your diagnosis, then you're liable to have very long-term relief.
So both of you are emphasizing how essential it is to confirm the pain generator before cryo treatment. And Dr. Agnes already mentioned the diagnostic block, how important it is for success. So Dr. Agnes, could you explain more about how precise diagnostic block should be and why it's so important?
This may be my favorite question because you cannot succeed if you don't know what the actual nerve that you're working on. A cryo ice ball that the cryo probe makes is only, let's say, this big. It's very, very little, right? It's enough to incorporate a nerve, but it's not going to freeze other surrounding tissue. It's not going to freeze the muscle, the fascia, everything. So that means that my diagnostic block needs to be exactly, perfectly, precisely the nerve that I'm going to freeze. So which is why actually I always do my diagnostic block myself. Even if a patient is sent to me by someone else, I will repeat the block I will make sure that I can visualize the nerve. I will make sure that we are talking about the same exact nerve as a target. And then I can cryo. And the other thing I usually tell the patient, it's very difficult for the patient to come up with numbers for the pain. It's very often they give very confusing answers. So what I do, I actually use, typically I use 2% lidocaine, very small volume, and immediately while they get off the table, while they're putting their shirt back on, while they're getting dressed, you can already see, and the patient can tell. If they say, "Oh, this is heaven, thank you very much," that's my cryo candidate. If they say like, yeah, maybe yes, maybe no, not so much yes, no, I don't cryo them so much because I want the successful, I want real success.
I would have to agree and add that I could do the world's best appendectomy, but if the problem is your gallbladder, I can't get you better. So I can't get you better if I don't approach the right nerve. And I think it's also key for people to realize that the amount of relief they get from the cryo is predicts what they will get when they get the procedure. And that I have to agree with Dr. Stogitsa. Other than Dr. Stogitsa, I don't trust anybody else to do my diagnostic injections. I've
I
had
want you
people.
to say, Andrea, that maybe if you do it, I would buy into it. Not really.
I said maybe. I said maybe. Uh, um,
Maybe.
I've, I've had people who sent me a patient for cryooccipital. And I say, well, how did you do the occipital injection? Oh, well, I
That's
did 10
easy.
cc's local anesthetic, fanned all over the back of the head. Well, this, that's a shotgun effect. I've got a laser sighted rifle that's very, very precise, but it won't match this wide area of local anesthetic. So it because it's such a precise technique, it needs a precise diagnostic injection.
I think we can almost even say that a good diagnostic block is also a bit of a prognostic block. Will it work?
Yeah.
Yeah. Also,
And
what
I actually,
patients will
the
say,
other
well, can
thing
I?
is how you, sorry, I apologize.
Go ahead.
So I'm always telling my patients it's nicer to under promise, over deliver. So once we are happy with the diagnostic block, I will say that the cryo will be only 50 to 75% as good as a diagnostic. And then typically we can achieve a happy patient.
Okay. And this is
I
also
would
what I'm
also,
heading. Sorry. Yes,
I would just make one
please follow.
small comment as well. The patients who say, well, will I be able to walk after this? And I say, well, this is the diagnostic injection predicts what you will feel with the cryo. And so it also helps the patient understand that this is a feeling nerve usually and not a motor nerve.
Mhm.
Sorry, go ahead.
No, that was just perfect because I was also, the next question is heading to clinicians, referring to what during the procedure, watch the ice ball. So this is what's actually happening during the procedure. You're watching the ice ball. So Dr. Trescott, could you describe what that means in practice and how you ensure the nerve is fully incorporated into the ice ball during the freezing?
Well, I think it's key. I started this doing them just landmark guided, using the peripheral nerve stimulator to be able to hone in on the nerves. And the closer I got to the nerve, the more they felt a tingle or a burn. And then started doing fluoroscopy. But nerves have sometimes some bony landmarks, but for the most part, ultrasound is um, dramatically a difference, has provided a degree of precision um, that is really unparalleled. So you can watch the size of the ice ball as it grows. You can see that the ice ball only gets to a certain size before it then starts to not grow anymore because the ice is the insulation. So then you defrost and then refreeze, and you get a bigger ice ball. And you can look at the relationship between and the nerve.
Mm-hmm. Okay. And Dr. Stagica, what do you prefer? What are the most important indicators that the procedure is technically successful, both under ultrasound and or fluoroscopy guidance? And which one of these you use more often?
The more tools you have and the more tools you can combine, the better certainty you can get. So talking about peripheral nerve, which is, I think, clearly the area where cryo has advantage over other procedures, what I want to see, first, I already had a successful diagnostic block. I save the image so I can identify that exact same little nerve next time when the patient comes back for freezing. So I have the nerve identified. I use ultrasound, and what I want to see a nerve, ice ball, nerve sequence. So I scan nerve, ice ball, nerve, nerve, ice ball, nerve. So I can see that the ice ball actually incorporates the nerve. That makes me happy. And if the patient is not under sedation or not under too much sedation, then they can actually also confirm that, oh, this is it. And in some areas, for example, for intrapatellar saphenous, it's such a nice little superficial target that I like doing when the patient awake, and they say it's this one, and then you freeze, and then it's not so nice for about 20 seconds, but then it's okay again.
Yeah, it burns for about 20 to 30 seconds. In fact, almost on the timer at 30 seconds. I'll say, is it getting better or worse? Tell me how you're doing. A couple of big breaths, and they'll go, and the timer will go 3 seconds, and they'll go, oh, okay, it's easing off. And so it makes a very nice confirmation, and then the rest of the procedure is totally painless.
Okay, that's nice. That's amazing. So, and now if we would talk about, because we are getting to a practical side for a moment, and there is a saying, and you already a few times have mentioned that cryoanalgesia is simple to learn, but this mastery takes experience, right? So, Dr. Trescott, from your years of experience, what clinical insights or small details make the difference between good and a great outcome?
Well, the first has to be that you actually have to recognize that the nerve is causing the problem. If you don't understand anterior cutaneous nerve entrapments, you won't look for them, and then you won't find them, and then you won't get the relief. If you don't know the infrapatellar saphenous is a nerve that gives a lot of the pain for the knee, you won't examine it, you won't do the diagnostic injection, you won't get the relief. The second thing I think is that it being meticulous about placement of the probe. Ultrasound, I use the peripheral nerve stimulator that helps me hone in on it, but as much as you can do to be precise in your placement of the probe. And it is, I think, a matter of understanding anatomy. So, and then understanding the risks. How do you do the intercostal as safely as possible? How do
Yeah.
you avoid the mistaking the femoral nerve for the lateral femoral cutaneous nerve, sorts of things. So you really have to understand the anatomy, understand the index, and understand the best approaches. So, Aggie, would there anything you would add to that?
I think it's pretty complete with this and the previous conversation we had.
Yeah. And so then there is because you're choosing the probe, and this also all the choices and patient selections is so crucial. So which one probe, the thinner, the more thick you are using, Dr. Agnes? When you already have everything
Like this
like matched,
question.
this is also regarding the probes when you're doing the procedure.
So, look, Every indication requires a different probe, I would say. But if I want a general approach, the bigger lesion, the bigger success. But you cannot always use a big needle. Like in the supraorbital nerve, I cannot use a big SI cryo probe. Unfortunately, it wouldn't be nice, right? So
Right.
it's, I would say it's mostly common sense. For a small nerve, superficial target, you don't want to or freeze the skin too much. You have to use the smaller needle. Uh, for a knee cryoablation, when if done right, there is really nothing in the vicinity that you could damage. There's no major nerve, no major blood vessel. What I want with the knee is to incorporate all the capsular nerves, right? I don't even see them. So we already know from the studies that if we freeze at the front, at the back, bigger lesion, better outcome.
Yeah.
And my preference typically, I know you guys make a blunt and a sharp probe, and I have to
Right.
say, I almost always use the probe that you call sharp, because even that sharp probe is not that sharp, but it's not much easier navigation than the blunt probe for me. I don't know if Dr. Trescott agrees, but I find it less traumatizing because it's better manipulation, and I'm done.
I
Okay.
do always so it
You
doesn't
do
really
all what?
matter to me whether it's sharp or introducer. So I use a sharper, an angiocath or something along, and place that on the nerve, and then take out the stylet and put the probe in. So to me, it doesn't really matter so much whether it has a trocar or a blunt tipped. The only thing,
Mhm.
what time that might make a difference is maybe around a blood vessel or the lung. But even then, we're under ultrasound, you're seeing those structures. I think there are times y'all are making a lovely curved probe for some of the situations where you want to go around a structure, or you want to be able to freeze two different directions with the same pass. There are some specialty probes that y'all make, and quite interesting. I can't use them in the United States yet, but I've had the privilege of using them in Europe, and they've been quite interesting, quite successful. Um, so I think, like any good carpenter, you pick your tools. You have a straight, um, a slotted screwdriver, or a Phillips head screwdriver, or a short one, a long one, a big hammer, a little hammer. You have all sorts of tools, and you pick the right tool for the right indication. And the same is true here.
And it's actually a very common question among clinicians because when they have a range of probes and they need to choose off, they often are asking about this, how to choose the probe. And from what we are talking now, I understand you need to be creative, and even sometimes the knee probe can be used for the shoulder, right?
Yeah,
Correct.
once
So
look,
maybe,
So
once somebody understands the anatomy, which is very important, you know the anatomy, you understand the potential risks, then I think you can make the right decision picking the probe. And if you don't know the anatomy, then you need to go watch and look more.
okay. Okay, that's great. We already also covered a little bit about the patient journey, right? How to prepare, what does your patient need to know before the procedure? What do they need to know, and what can they expect after the procedure? So maybe let's talk a little bit about patient expectations. How do you, Dr. Stogica, manage your patient expectations? Because that's also a part of success.
I think it's a big part. I think someone with, let's say, super bad shoulder osteoarthritis who's coming for a shoulder denervation, they cannot expect that their shoulder will be again 20 years old and perfect and go play basketball. So you need to prep them that what I can almost promise is that the sharp pain that when they reach for the cupboard will go away. That I can almost promise. But there is still going to be a resting pain, even with the successful diagnostic block. So setting expectations well, I think it's really part of the success. But again, depends on what you do. If I think of Dr. Trescott's one of the favorite indications, imprapatellar saphenous, that works awesome. Like you do it, and the pain is gone, like gone, right? But even with that, I prefer promising a bit less. And if the pain is gone, then I can really feel good about the whole program.
Okay.
And you're
Okay,
the
Dr. Trescott, would you like to add?
I do ask them to keep some proceed on the site for a couple of hours to help with soreness. I explained to them that it is a surgery, that there was a procedure that was done, and but I don't usually need to give my patients any kind of opioids, and they're usually quite comfortable afterwards. It's just a matter, and I remind them that they haven't been doing walking for a long period of time, for instance, and they want to go out and walk 6 miles, and then they come back and they're sore and they're complaining, and I'm going, well, you haven't been using those muscles for a while. So I ask them just to keep the activity low, gradually increase the activity, not to go out and run a marathon, at least until they've been practicing a bit.
Okay. Okay, so thank you very much for these elaborate explanations. I think our listeners are going to do the diagnostic block, find the location, guide their properly, and then set the patient expectations. But so let's move on maybe. Cryoanalgesia has been used for intercostal nerve application, for postoperative pain, and of course for peripheral nerve pain. And we see that with postoperative pain, the tendency to use cryoanalgesia is growing. And I wanted to ask both of you, how do you see the role of peripheral nerve cryoanalgesia evolving? Doctor,
Well, I think the recognition of the nerves has been a big part of it. When you didn't know that the nerves existed, then cryo wasn't much use. So as we've begun to recognize more and more nerves, as clinicians have recognized it more, I love cryo that done preoperatively for postoperative pain, though I do have to warn my patients. I started out doing the infrapatellis preoperatively for outpatient knee replacements, and all the patients canceled their knee surgery. And the surgeons were not happy. So I had to explain to them that they still had a very bad knee. This was for postoperative pain relief, and I started doing it the day before surgery, and just trying not to make enemies of my surgical colleagues. So the relief for the intercostals, for things like the pectus excavatum surgeries, where these kids and young adults are going home that day with no pain and no pain medicines, is just very, very exciting. So doing it preoperatively, doing cryo intraoperatively, doing cryo postoperatively for the patients who didn't get good analgesia is not my favorite way of treating it. I always prefer to do it preoperatively, but it can provide patients with hugely significant relief, and cancer pain, and CRPS, and postherpetic neuralgia, and Aggie, what am I missing? It's a tremendous number of indications as we do more. And I'm afraid their dog, something just got all the dogs excited. So I'm gonna go mute for a minute.
It's okay. It's okay. And we are out of time already. We have we have 1 minute left. So I will ask you, Dr. Agnes, maybe to say a few words like home message, or some kind of like a sentence for those who are hesitating to try cryoanalgesia, so that they could start, and how to encourage them.
Always, when someone asks how to start, I always say start little and pick an area that's hopefully not a high risk area. Start working there, get some success. I say it's very nice to start with major joint denervation because it's safe, it's successful, it gives you the courage to go. And then as someone gets further in their career and you can see peripheral nerves, if there is a nerve injury, especially if it's a big myelinated nerve, maybe cryo is your answer and it's time to move. That is the area where it has a clear advantage over radiofrequency. Because while you can use radiofrequency for denervation of joints, for peripheral nerves, cryo is clearly better. So maybe that's also an area where you want to partly start and improve to help those patients as well.
Amazing. Thank you both for such a rich and insightful discussion. And Dr. Trescott, would you like to add something like, encouraging sentence for the end of our conversation for those who are starting?
Begin, the rest is easy. It is recognize that this is a very useful tool. As Dr. Stogitsa said, start with something simple, low risk, and high yield. And so I would vote for the because there's an awful lot of people there with knee pain. So a good place to start.
Okay, so on behalf of Metrum Cryoflex, thank you, Dr. Trescott and Dr. Sogicha, for sharing your experience. Thank you all for joining us, and please stay with us for the next panel as we continue. Thank you.